Everyone, and welcome to this first scientific session in the Hall B of this wonderful conference. This absolutely new concept and a great beginning that we are having in India. This is the World Conference, and so many thousands of people have joined us, not only from India but abroad. And we are going to have some wonderful, diverse, and interesting topics, a discussion on them, and lectures delivered by our honorable guest faculties. So, to begin the the first session, I would request and invite our chairpersons, Dr. Ashish Dhingra. He's a good friend and he's a renowned diabetologist and endocrinologist from Jabalpur, and Dr. Saurabh Srivastav from Noida. He's also a renowned diabetologist and endocrinologist to chair the session and introduce our speakers and take the session forward.
Thank you, Rajesh, for your kind introduction. And moving on to the India's first DTechCon, which is the innovative conference which is organized by Bansi Saar and his team. And I invite our friend Dr. Mithun Bhartiya for the interesting talk which will be heard in a few minutes. He's MRCP UK and MRCGP UK, MRCP UK, Founder Secretary of Association of Clinical Endocrinologists, CCT Diabetes and Endocrinology UK. He has done MBBS, MRCGP, MRCP from UK and FE CSM Amsterdam. And he was in Mayo Clinic USA. FE CSM was done from Amsterdam, and he has received the Newman Prize for his work in 2013 on diabetes, testosterone, and erectile dysfunction. And he represents India at the Worldwide AGP Clinical Academy. He is a national and international faculty and National RSSDI Technology Task Force member. And we all know him. He's a very good orator. Over to you, Mithun.
Thank you, Ashish. Thank you, chairpersons. And thank you, DTechCon. I think it gives me great pleasure. I'll just get my slides up. So first of all, is my slide visible and moving?
Yeah.
Yes.
Okay, fine. So the topic that I have been given is technology advancements in erectile dysfunction or sexual dysfunction. I think the biggest advancement in sexual dysfunction diabetes that we have started discussing about it in meetings. I think this, if you ask me what is the biggest advancement, that is the first universal step that has happened to acknowledge that the problem exists. You can only fix a problem if you are aware that the problem exists. And I remember when I had come from, the way I had gone down to start sexual dysfunction in England was I was doing my endocrine training and patients had come for problems with their sexual life. And my professor sent me to a sexologist, says, uske paas bhej do, kya karega, aafat hamare sar se chali jayegi. So with that, inquisitiveness is the mother of creation. And that is how I embarked on a journey of sexual dysfunction with the person, Dr. Hackett, who I always acknowledge as my guru, who started my training in it. And it has evolved. Things have evolved to the point of understanding where we are. Because when I started my practice in India, I think there were only a few people in diabetes who actually do diabetes and sexual dysfunction. And I was actually said, "Bhai, tum kya karoge? Tum to PD5 inhibitor doge, wo to hum bhi de denge. Why should we refer the patient to you? Wo to hum bhi dete hain. What is the big thing?" So I'm going to start the story from there, use some recent advancements and what is there in the future in this talk. Now, we all talk about PD5 inhibitors that have been there. So what is the newest invention in PD5 that has been there? See, PD5 can be broadly classified into short-acting and long-acting or the weekender tablet, which is Tadalafil. For Tadalafil, it works in your body for 48 hours. And, Sildenafil takes around half an hour. So you have to take the tablet and wait for half an hour. And that has always been the biggest criticism. Plus, it is non-specific to PD5. So people get a lot of flushing headache with sildenafil and other medicines. So the newest addition to the block, which has been started in India in the last 1 or 2 years, is Avanaphil. Now, the beauty of Avanaphil is that the onset of action is around 15 to 30 minutes. So you can take it as early as 15 minutes before sexual activity. Now, in India, even though we are the land of Kama Sutra, foreplay is actually not given much of importance. I think 15 minutes is kind of the right tick box for everybody to actually have the onset and have a good mechanistic action. And the advantage of this is that it is more potent on the PD5 than on any other phosphodiesterase inhibitors. So these are the two unique advantages with this molecule, which is the next gen or the recent addition to the PD5 inhibitors that are there in the market. Obviously, you need to know, not to use it in end-stage renal and hepatic impairment, severe hepatic impairment. But the point I was trying to make is that we have now far more specific PD5, the technology advancement in PD5, than generic that we used to use. Now, however, with PD5, there's always been some kind of a criticism. See, boss, sex is spontaneous. You cannot plan sex. You can, but it's very difficult to plan sex. And a lot of patients do not respond to PD5 inhibitors. And they do not get unsatisfactory hardness. And with passage of time, either they develop some resistance to it, and there's a dropout, and they keep increasing the dose. So people want spontaneous sex. So what is the next step that can be done for that? And this was the newer technology advancement that happened, is the addition of shockwave therapy to sexual dysfunction. Now, what are shockwaves? Shockwaves are impulse of acoustic energy propagating with supersonic speed in the liquid or gas. It's a natural phenomena. As you can see, a steep rise of positive peak pressure and short duration, which is there. Velocity is around 1500 meters per second in water. And this has shown to have some improvement in erectile dysfunction. Now, the whole logic that it works, shockwaves work, it has been used in various things, which will come in the next slide. And it causes neovascularization and developing new collaterals, or reducing, I think some new theory has come, it works in reducing peripheral resistance to the blood flow that has been there. Now, it's not something that is new. It's not something shockwave, I'm saying, which is not existed, suddenly it was discovered. It has been there for lithotripsy. When we do lithotripsy, we use shockwave applications, and it's been used in orthopedics for injuries, in cardiology, and that has got into erectile dysfunction that are there. Now, how does this, the landmark paper that came with this was the extracorporeal shockwave therapy, which markedly ameliorates ischemia-induced myocardial dysfunction in pigs in vivo. So this was a landmark study which was published in Circulation in AHA, which actually was the start of the events of considering shockwave in treatment of that. Now, how does shockwave actually work? Shockwave causes shear stress, which increases intracellular and extracellular response, stimulates endothelial cells, nitric oxide synthesis, release from vascular endothelium, growth factors, causes proliferation, nuclear antigen production, and some neovascularization. For each of these, there are a lot of data that has been there, which suggests how it works. So cavernous cell tissue responses to shock therapy. It activates nerve repair. It restores normal endothelial signaling. It recruits immune cells, initiates wound healing, recruits stem cells, and activates resident stem cells. Now, there are numerous machines that are available. The ED1000 was the first machine to come in the market. And there are various machines that are now available in the world which uses this. This could be the Duolith, the Aries, the Renova, and the PiezoWave 2. In the initial ones were focused on electrohydraulic, and the newer ones are electromagnetic. It's very difficult to say which is superior, which is not, whether electrohydraulic is, there's more data with the electrohydraulic, but this is not that the generation has evolved, iPhone 5, 6, 7, 8, 9, 10. It's just two different ways of looking at the same concept that exist. Now, this was all started by, the first study by a very good friend of mine, Vardi et al. And what he showed, and I was in European Society of Sexual Medicine meeting long ago when this paper was presented. We trained together in Oxford. And they do 6 sessions in 3 weeks with a 3 weeks gap and a 6 sessions in 3 weeks. The 300 SW is given per each side, 2 at the crura, 1 at the tip, 1 at the medium, on the base, not on the foreskin or the glands. And the next time when the patient comes in the next session, it's given on the other side of the penis or the corpus cavernosum that is there. So alternate sides that are there. 300 shots per side, so around 1500. It's not a painful process. People may feel the sensation the pressure sensation that exists. I've used it for a long time and over the years. The other, you need to use a little bit of jelly to reduce the discomfort that the patient might feel. There are no side effects that the patient might have. It is not 100% guaranteed solution. What it might do is reduce the severity of erectile dysfunction and help the non-responders to PD5 convert into responders, or improve the grade of the erection. But it is not a magical cure. And I think that perspective has to be kept in mind when we are actually advising patients for it. As a rough guide with the data, it says 50%, it works in 50% of patients. But, I think over the time I've found that the percentage of patients that it works may be a little lower. So one has to tease the vascular path in the erectile dysfunction that is there. Somebody who's an arteriopath, somebody who's got high blood pressure, somebody who's got coronary artery disease, somebody who's got blood cholesterol raised, it is more better chances of them responding to this LSWT therapy than a psychogenic erectile dysfunction that might exist with patients. So it's important to tease out that, because we are much aware that erectile dysfunction may persist 3 to 4 years before a myocardial infarction, purely of the diameter of the penile artery, which is 1 mm, as compared to the diameter of the artery of the heart or the femoral artery, which is 2 to 3 mm. The smaller the diameter, and it has been shown that the 50% obstruction of the lumen will precipitate in the symptoms. So it has been very much shown that ED comes much earlier of myocardial infarction in patients that are there. Now, this is how to use LSWT. Now, what are the tools to assess that are there? We have the IEF scores. People use penile Dopplers, and I would take the occasion to say that penile Dopplers are not very useful. Please don't use them. Please don't waste your money. Use them. They are the results are inconsistent despite having an improvement in IEF that is there. So I would never recommend wastage of patients' money to do Doppler studies for erectile dysfunction. I've done it, as you said, I've spent a good amount of 10 years or 12 years in this line. So I can tell that I don't use any Doppler studies. Clinical evaluation followed by investigation and treatment is much better than wasting the money, because the expectation, sometimes I often find people writing arteriogenic ED or venogenic ED, and it gives a negative feedback to the patients, because very often I said I have patients who've got brilliant erections, improvement, but the Doppler has not shown significant improvement. It doesn't matter what you can see in front of your eyes. A picture will say 1,000 words than a numerical value or the study. Your patient can feel the difference. Patient's happy and satisfied, and yet sometimes the Doppler does not show this. Now let's move on to something which is vascular functions. You see, the artery, the diameter of the artery, as I said, of the penile artery is very small. And the normal artery of a normal person is like silk. Nothing sticks to it, nothing passes to it. Whereas the diabetic artery is very much like Velcro. It's very, very sticky. So an endothelial damage is very much there. And in the vascular function plays a vital role in the vascular tone and the blood flow regulation. So if we could assess this function, it might be a more practical way of measuring endothelial function that are there. Now the speed, let's go to some physics, which I've forgotten in a long time. Speed of the wave is related to the stiffness of the artery it is traveling. So stiffer the artery, the higher the wave speed. And so the wave speed is proportionate to the square root of the arterial thickness that are there. Hence, if we can assess the pulse wave velocity of larger arteries, it might be an index of arterial stiffness and allow us to consider treatment which work on the arteriogenic erectile dysfunction, which can be there, and help recognize as an early risk factor for a lot of patients. Because as we know that diabetic patients are a ticking time bomb for cardiovascular disease. We can use Pigmompocore system for measuring central blood pressures. These are the newer technology. Or we can use brachial artery ultrasound with endothelial dependent flow mediated vasodilation blue. So this is how we could assess it. Now, what are the newer techniques that are in the pipeline that are there? They are platelet-rich growth factors which can modify endothelium. So concentrated plasma consists of many such growth factors. And platelet-rich plasma, PRP therapy, which you can see, you give to people who've got hair loss, And that has also shown that with the interaction with the surrounding cells and intracellular matrix and mediator at the site of injection leads, this may show improvement because there are a lot of growth factors associated with platelet-rich plasma, which can improve the erectile dysfunction. And the regeneration effect continues across 7 days of life of platelets, and it stimulates cellular proliferation and tissue regeneration of the endothelium. The other new thing that a lot of work has been done is stem cell therapy for erectile dysfunction, and this is work in progress. And cells have been derived from multiple tissues with varied potential and may function via local engraftment or paracrine sealing. So we have stem cell mechanism of action, we have PRP mechanism for action, and I think what is going to happen with passage of time, that ED would become the window to look at the cardiovascular profile of the patient in terms of deciding a lot of therapy that is going to happen. Because very often we say, yes, we have got studies with patients with cardiovascular disease, but we know there's an underlying population with undiagnosed cardiovascular disease. And this is erectile dysfunction with newer ways of finding out the arterial stiffness, with the newer ways of treating the arteriogenic ED. I'm sure ED would become a forefront in the discussion that is going to come in the coming years. With that, I'm just going to say the change that has happened with the pre and the post Viagra era, it was erectile dysfunction is post-pill era is organic in most patients unless proven otherwise, which is over 40. This is a historical fact. And things have evolved to look at ED in a vascular, neurocentral, peripheral, visual, tactile formation to understand the molecular physiology. And once we can assess the endothelial dysfunction, we can give better service to our patients to lead a definite and a more productive sexual life. With that, I would end my talk. Thank you so much, which is there. These are the conclusions which we had. Thank you so much. And thank you, Rakesh, again, for twisting my arm, for getting me to talk on this topic. Thank you so much.
Thank you, Nitin, for wonderful new things which you have discussed today here, and you have opened the minds for future therapy, as this is a technology future conference. Over to you, Saurabh.
It was a wonderful talk by Dr. Nitin, and as we have discussions in the end, so I just invite Dr. F.R. Arvind for the next talk, and the next talk is on artificial intelligence in diagnosing diabetic retinopathy. And Dr. F.R. Arvind is not a new name, we all are familiar with him. He is Director and Chief Diabetologist of Diacon Hospital, Bangalore, India. He is Course Director, PG Studies of Health University, RUGS and RSSDI. He is President RSDI from 2015 and 16. He is President Diabetes India and has over 100 papers and conducted 100 phase 2 and 3 clinical trials. So over to you, Dr. Arvind, for your presentation. Artificial intelligence in diagnosing diabetic retinopathy.
Thank you, Saurabh. Just somebody to tell me that you can hear me, and then
yes, sir. Yes, sir. You are audible.
You can see this one. So with that, I'll be sharing my screen. Just let me know if you can see the screen well.
Yes, sir. Screen is visible.
Okay. Thank you so very much. I think I'll be concentrating basically on an important part about diagnosis of diabetic retinopathy, especially using the fundus on phone and artificial intelligence, which is actually a gift from our own country. And of course, these are my disclosures. See, it's important to remember that eyes are the windows to vascular health. Comprehensive treatment has taken so much of our efforts, but sometimes as physicians, diabetologists, and endocrinologists, we are not really completing our comprehensive care because we fail to actually evaluate the diabetic retinopathy, which is the most important microvascular disease, because once you diagnose diabetic retinopathy, you know that it's the first step, and then your focus automatically goes on the liver. Well, I love dogs, and this is a beautiful photograph, but blindness certainly is not the way that we should actually see our patients at any time. And this is exactly what's been happening with 77 million people in India. 1 in 3 have diabetic retinopathy, and 1 in 10 actually have a vision-threatening diabetic retinopathy. Now, if you look at the data from IADP, this was actually way back in 2010, 2012. It's about 45 million people have vision-threatening diabetic retinopathy. We don't have the full data from India, but it's safe to say that 30% of our individuals with diabetes have diabetic retinopathy. Well, we have been never trained during our MBBS days, and all MS ophthalmologists are also not really trained because the retina specialization has come after you complete your MS in ophthalmology. What we have been doing as physicians is, of course, to refer patients for a dilated fundus examination by an ophthalmologist, or we have been taking retinal photograph and sending it to our colleagues for a teleophthalmology consultation. See, there have been a number of challenges in this because access to a retina specialist is still less in smaller cities. You will have ophthalmologists, and trust me, all are not trained. And you need to travel to a different hospital. So that brings in the time and the cost. When once the pupils are dilated, you have blurring of vision, so you can't drive back. So many of the patients will not go. And teleophthalmology showed a lot of promise in the rest of the world, but unfortunately, there is a tremendous amount of intergraded variability and delay, which has actually made this possibility not very suitable, especially for a disease like diabetes. In fact, more than 70% of our patients are not just screened because they have to travel to the ophthalmologist. Now, the second important thing is it's so asymptomatic. Even sight-threatening diabetic retinopathy is so asymptomatic, your patient will not take you so very seriously because he thinks, oh, well, it's just a check for my glasses, so he may not actually go. Now, the question is actually who should now screen? In a country like India, we have approximately 1,000 or maybe 1,500 retina vitreous specialists. That's it. And this is the data from the Indian Ophthalmology Society. You have fellowships in medical retina after your MS, and you hardly have 2,000 to 3,000 medical retina specialists. I mean, this is the truth. So everyone with an MS ophthalmology degree is not a retina specialist and can make very, very bad mistakes. So when it comes to teleophthalmology, the big question that we have to ask is, how reliable is the reporting itself? I will not go into too much of details because about 5 to 6 years back when we started working on artificial intelligence and trying to perfect it, we looked at all the possibilities, and there is a tremendous amount of inter-observer difference, and these are some of the papers. And we ourselves looked into the differences that can come when 5 very senior retina specialists are asked to grade the fundus images, which is blinded to each other. And it's what is known as a Kappa Score. And even for severe NPDR, the Kappa Score is as low as 0.32. You get a Kappa Score of more than 0.6, I think there is a fair amount of agreeability among the people who are grading it. And this is a part of the SMART study which got published later. Now, even when we wanted them to grade DME, which range from mild DME to moderate DME to severe DME, in fact, the Kappa score was only 0.4. Okay. And even the best of the retina specialists obviously know that when you are looking at an image, it's very, very difficult to actually pick up diabetic macular edema. It's not all that simple. And this is something that we have to now share with all our colleagues. Well, there are reasons for this, okay, because we don't have dedicated centers in India. Some big hospitals have their own branches and their own units, and their doctors are well trained, like Dr. Mohan's place can afford to do this because it's well-trained staff. And there is no training to ophthalmologists who are not retina specialists because this is at least a 1-year fellowship. And for most ophthalmologists, it is not the mainstream of work. So they would not really concentrate on something which does not have a surgical implication at a later time. And then there are things like the experience, the doctor fatigue, the image quality, the pixel size, the reader screen type, internet issues, a number of other things. You know, when you send an image on a WhatsApp, usually, in fact, the quality of the image itself comes down by 10 to 20%. And it depends on what type of a screen you're using to actually see the image, which camera has actually captured the image. And there are so many other things. I'll not go into the details. Now, the question then is, if the physician does not screen for DL, then the patient will actually go blind. Now, we have to find solution. The cost-effective fundus camera, it's just like an ECG machine. Every physician has an ECG machine today. And a cost-effective fundus camera and artificial intelligence, I think, is the solution for DR screening worldwide and not just in India, because this is a problem that's going to be faced by every doctor, every physician worldwide. I think this is the answer. And artificial intelligence is so good with retinal imaging. I'll be talking about the Medio's artificial intelligence and where they stand today, etc. You'll be amazed at the sensitivity and the specificity that this particular artificial intelligence is giving in terms of referable DR versus no referable DR. So we must understand there are two types of artificial intelligence used, and one can be cloud-based and other can be offline, which is on a smartphone and in the camera itself. Now, the cloud-based one, you need expensive cameras, you need electricity, you need internet, and then the images are captured and your AI is cloud-based, and then you get a report probably in about 4 to 5 minutes. Well, it's a very, very expensive alternative. Now, the simple alternative is if you have an offline fundus on phone, which is very inexpensive, you have artificial intelligence support, and it does not require an internet connection. It does not need electricity. The camera cost is roughly below 3.5 lakhs, so everybody should be able to afford it. It may go down further in the number of years. And the reports are generated in less than 15 seconds. And this is very ideal for screening in developing countries, and also take it to a number of your camps. And what is the accuracy level that the FDA is looking for? A sensitivity of 85% and a specificity of about 82%. And these are some of the cloud-based AI algorithms that we have. In fact, the iArt and IDX are the only two cloud-based AI algorithms which are now FDA approved. And this again is not being used in India because it is very expensive, and they have been tested against very high-end cameras, and they have not been tested against the inexpensive cameras that we have been going to talk about. So the question is, the cloud-based AI algorithm suited to all? Definitely no. The cost, the convenience, the need for internet training of the person, delayed reports. These are the reasons why we say that this is not going to be the solution. So the Medios from Singapore have come out with this offline AI revolution. It's the automatic detection of diabetic retinopathy. It's fitted on the phone of the Remedio, which is actually manufactured in Bangalore and India. And this particular fundus on phone is FDA approved and costs less than 3.5 lakhs. And when once your artificial intelligence is already embedded onto the system, the processing and the reporting time is less than 15 seconds. And on the right side, you can see the analysis with a confidence level of 92 to 99%. It looks at the image quality and the confidence level of the DR. Now, whenever somebody comes out, you need to actually see how exactly this is going to work and how exactly you're going to do the validation. Now, this is where we came into the picture because we were actually asked to validate this. So we did two studies. In fact, the SMART study, which looked at 922 patients, non-mydriatic images, we took 2 images per eye. And the SMART study 2, which had 304 patients, mid-Adriatic images. And on top, you have the 3 images, and on the bottom, you have the 2 images. Now, what we did was we had different retina specialists blinded. The diagnosis also was taken from the AI, and it was compared with that of the retina specialist. So the AI could give us 3 types of diagnosis. One was referable DR, or all DR, or a sight-threatening diabetic retinopathy. And this is exactly what we found when it came to the referable DR. The sensitivity was about 98.4%, and for sight-threatening diabetic retinopathy, it was 100%. In fact, this paper was published at the Indian Journal of Ophthalmology. It was presented at ATTD and several other conferences. Then we also did the other SMART study, where this was the largest, in fact, 922 patients using the same Meteos AI and the FOP of Remedio. And this is the largest so far, and this was published in the BMJ Open Diabetes and Research. And in this particular study, it was non-mid-Adriatic, which is quite tough among Indians because your pupil size is less than 3. We were still able to get it, and the sensitivity was 93%. And the sight-threatening DR was 98%. It far exceeds the FDA cutoff of both sensitivity and specificity. Now, we have the good results. Now, can we use it in the real world? At that time, in fact, Professor Natarajan from Mumbai was the president of the Ophthalmology Society of India, and he wanted to see whether a layman can be tried. And he tried using this camera and the AI actually to screen for diabetic retinopathy in a regular public population. He took it to the municipal council, and people were trained to actually take the fundus pictures, and they were able to get the diagnosis. And the sensitivity was 100% for good quality images, and specificity was 88%. And images of good quality and poor quality, when you mix both, for referable DR, surprisingly, it was 100%. And this again was published in JAMA Ophthalmology. So very clearly telling us that it can be used by anybody. And all that is required is about 30 minutes of training this particular people. And the study highlights from Dr. Natarajan's thing is deep learning and AI is here to assist us. The most important thing with the Remedio FOP and the AI from Meteos is it works offline on an iPhone. Apple also came into the picture at this time, and they made sure that they can help the people who have actually built it with some of the modifications that was necessary on their iPhone. In fact, the sensitivity and the specificity of the Meteos AI with both mid-Adriatic and non-mid-Adriatic images far exceeds the FDA mandated superiority. So at this point of time, it's awaiting the FDA's recognition. When once it happens, it will also be used freely in United States, and it's already available in the rest of the world, especially in Europe and other places. And it has also looked into the differences in performance, especially related to ethnicity, because when you look at a retina, the retinal pigmentation can change from ethnicity to ethnicity. So even this has been seen and found to be perfectly fine with this. And there were several companies which said we already have images from other desktop cameras. Now, can we use the AI for our images? And these are some of the work that has been done. In fact, it has also been presented. Now, what is going to be the future? I think the future is going to be to move into the binary diagnosis and to see whether the staging is possible, like mild, moderate, severe NPDR, and that work is already started. And the most important thing is to pick up glaucoma and age-related macular degeneration, which is very, very important in our population. And the future, of course, can we look at a retinal image and try to have a CV score with a lot of other data coming in. In fact, this was presented in AVO 2020, where the staging of no RDR, that means no referable diabetic retinopathy, it can also include some mild NPDRs. And RDR means a moderate NPDR to severe NPDR to PDR, and a sight-threatening diabetic retinopathy actually includes severe NPDR and PDR. Now, at this point of time, what I would like to say is, this is not going to replace an ophthalmologist, but it will help a physician to make a quick diagnosis and then probably to refer the case to the ophthalmologist. When the AI says it's moderate or severe, this is a referable DR. Now you don't hang on to the patient. Please ask the patient to see a retinologist. I think this is where it is going to come into the picture. And even with the binary classification, the sensitivity specificity is extremely good, far exceeds the FDA. And with glaucoma, we are pleasantly surprised. This is the work that has been going on to actually pick up the glaucoma reports in less than 10 seconds. These are some of the validation work that has been done with respect to the glaucoma. So I've just listed a number of conferences and number of publications that have already come out with respect to the Remedio FOP and the Medios AI, and the work actually continues. Well, the screening algorithms will definitely make retinopathy screening very accessible and affordable, because as physicians, we have been able to do everything else, but we are not completing our comprehensive care because we never really had an instrument like this. And the early detection and treatment can definitely prevent blindness. Well, so far, all the physicians and others have not taken it up. Well, we still live in a world that does not really exist. I think we have to now move and take on the responsibility and lessen the burden of the ophthalmologist. And I really request you all to join us in changing, because this is something made in India, extremely inexpensive, and giving us specificity, sensitivity, which far exceeds that of any other AI, which is also available or recommended by FDA in the world. So I would like to thank all my collaborators from Retina Institute of Karnataka, and a special thanks to Dr. Mohan and his team from this one, and Dr. Banshi and Jyoti Dev, many others who also actually helped us while we were evaluating it. And the evaluation continues, more work has started. I'm sure we'll be able to share more data about how AI is moving into the binary diagnosis and other areas. Thank you so very much. I think with that, I will stop my talk. And if there are any questions, I'll be happy to take the questions.
Thank you, Dr. Arvind, for a wonderful presentation and giving an idea about how diabetic retinopathy can be screened at community level also. And now we are at for the third talk, Dr. Ashish.
Yeah, so moving on to the third talk in this important DTech conference. We are having our renowned Dr. Vijay Vishwanathan, sir. Welcome you, sir, for the next talk. His present position is Head and Chief Diabetologist, MB Hospital for Diabetes, and Professor M. Vishwanath, Diabetes Research Center, Chennai. He is MD, PhD, FRCP, London and Glasgow, WHO Collaborating Center for Research, Education and Training in Diabetes. He is President-elect from 2021 to 23 for Diabetic Foot International, based in Belgium and consisting of experts from 193 countries. It is a proud honor for us. National Vice President, RSSDI, completed 29 years as a diabetologist, PhD in diabetic nephropathy, and published 50 research papers in this field. First Vivian Foncier Award from the American Diabetic Association for work in diabetes and tuberculosis in 2013. And he has developed a specialty of diabetic foot care in India by training over 2,000 physicians in the prevention of amputation, setting up a state-of-art podiatry center in Chennai since 25 years, and publishing 150 original research papers in diabetic foot. He has been awarded Fellowship of the Royal College of Physicians, London, for research contribution in diabetes. The field of interest is foot and diabetes, kidney and diabetes, diabetes in patients with TB, and socioeconomic diabetes. So I welcome the renowned Dr. Vijay Vishwanathan, sir. Over to you, sir, for your next talk.
Yeah, thank you, Dr. Ashish and Dr. Saurabh. I'll take only 12 minutes to finish my talk, but it's a very interesting talk. And let me share the slides. Yeah. So I'm going to talk to you on a new technology which we have used in Chennai for the early diagnosis of diabetic foot. So yeah, so now it's in full screen. So I'll take 10 minutes to take you through this new technology. First of all, we should know this point that as diabetologists, we have this classification, simple classification from our colleagues in King's College London, who talked about stage 1 when you have normal foot with a normal sensation, no peripheral arterial disease, deformity, and so on. Stage 2 is where the diabetologists are involved. Stage 3 is where, and stage 4 and 5 are where the physician has to call a surgeon, and the surgeon is involved. So this is for the diabetologist and this is for the surgeon. So today's talk is mostly going to be on stage 3, 4, and 5. And the next 11 minutes, I'll talk to you on this new technology. First of all, we should understand that in people with diabetes in India, the main reason for diabetic foot amputation is infection. This was a study which we published way back in 2005 in Diabetic Medicine, where we compared 3 populations, Germany, Africa, and India, and we found that the main reason for amputation in the developing world was progressive infection among the people with the diabetic foot. Which have noise there. So progressive infection is the main cause for amputation. Now, why should we prevent amputation? Why should we have new technology? So this was a study which we published in JAPI in 2013. And if you have people with diabetes who undergo recurrent amputations, minor or major, and compare them to people with diabetes who do not have complications, you find that people who undergo frequent amputations spend about 4 times more money than people who do not have any foot infection or amputation. So now I move on to my talk. This was one of our patients who came during lockdown, and this is not the ideal time to show this. An infected foot with a lot of maggots, and these are dirty maggots because of infection. And when you clean the maggots, you'll get an infected wound. You clean the wound and you get a good wound, and then you do a skin graft and you save the foot. In the next 10 minutes, I'm going to talk about a new technology which is called autofluorescence imaging of the diabetic foot ulcers. And this is using a novel artificial intelligence enabled non-invasive device. So this paper was published in the International Journal of Lower Extremity Wounds, IGLEW. And this is for the first time. When you get a person coming with a foot infection like this, you do not know whether it's gram-positive, gram-negative organisms which are present in the wound. We give empiric antibiotic and we do a culture and then we wait for the report. So this was a new technology which we used, which will hasten the wound healing and also improve wound closure rate. The technology is an autofluorescence-based multispectral imaging, and this has been tried out in some countries like the United States, and we used it in India. And it's a useful technique for the identification of bacteria, and it involves, what does it involve? It involves shining multiple wavelengths of light on the wound. So you just shine multiple wavelengths of light on the wounds and collect their emission responses. It will help you to understand, therefore, the pathophysiology and the bacterial colonization which is happening. It's a novel point-of-care device, which, as I told you before, is a multispectral autofluorescence imaging, which helps in rapid identification, classification of bacteria, which is growing in the foot. The study which we published in IGLEW was aimed to evaluate the diagnostic accuracy of this device in detecting the bacterial gram type against the standard culture methods. This device was developed combining multiple light source, you can see so many nanometers, to shine the wound, and it collects multispectral images in approximately 30 seconds to detect infection on the wound. There is an image processing algorithm which is available in the camera, which I'm going to show you, which analyzes the spectral images, and a pre-term trained machine learning algorithm will then compare the relative intensity between the different autofluorescence biomarkers, thus enabling classification of bacteria into gram-positive and gram-negative in just 2 minutes' time. It's non-contact, it does not require the addition of any reagents, and it removes a burden of interpreting spectral images. The artificial intelligence engine runs on the development and can be used even in remote places with no internet access. It's just a camera. And it provides a comprehensive report along with the automated wound measurement. It also measures the wound and also gives you the type of bacteria which is growing on the wound. It's easy to use and requires training to image the wounds consistently. It requires some amount of training. So this is a device, this is a camera, which we have been using for the last 2 years in our hospital in Chennai. It's used to collect multispectral wound images. This is a camera, and you need a dark room, or you can use a black hood covering the wound area. You have to train the investigator how to take the images, but once he or she, a nurse, is trained, he or she can take the photographs very easily. Before imaging, the wounds must be cleaned with normal saline, and then you enter the details into the imaging application. And the user was, in the study, was guided to image the wound at a distance of 10 to 12 centimeters from the area of interest. And in about 20 seconds, you can get about 16 multispectral images. Now, if you have a green color, which is shown on the wound, it means it's a gram-negative infection. And if you have a red color, as you see here, it means you have a gram-positive bacterial infection. So you can change your antibiotic when the patient comes in according to the color which you get. So gram-negative is green and gram-positive bacteria is red. In this study, we had about 178 patients who were studied, and the mean age was shown here, and most of them were men. And the duration of diabetes, most of them had a duration of 11 to 15, and most of them had bad wounds. We used the University of Texas classification, and most of them had bad wounds. Most of them had uncontrolled diabetes, and most of them were not on antibiotics before the images were taken. And these were the isolates from the wound by culture. Now, this is an important slide. We compared the culture. We did the culture on deep tissue during the operation theater. We took a culture and we compared it with the photograph taken from the camera. And you can see that among these 178 patients, we had about 203 cultures taken. And the correct diagnosis was in about 168. In 35, it was misdiagnosed. Therefore, it was a close correlation between the culture method and the novel imaging method which we used. Now, this shows you the positive predictive value and the negative predictive value, if it's gram-negative or gram-positive, and no growth also. The accuracy was quite good. And if the person did not have any growth of any bacteria, the accuracy was much more. And even if it was gram-positive or negative, it was a good 86%. The conclusions of that study was that the accuracy of the device was found to be about 89%, with a positive predictive value of 80.8 for detecting gram-negative bacteria and 86.3 for detecting gram-positive bacteria. The area under the curve of 0.86 showed a significantly discriminating ability of the device to the presence of pathogens. So it was a close correlation between no pathogens and pathogens by using this autofluorescence method. And there was a high sensitivity and specificity, which you can see here, which was shown on the study. Now I'll show you two examples of how it could be used in clinical practice. So this is not from the study, but this is from our experience after the study was published. This is a patient with necrotizing fasciitis involving the right foot and leg. There's infection here. You can see that it's mostly gram-negative bacteria, which is seen before the debridement. We did the first debridement, and the infection was opened up and the bacteria was cleaned. But you can see that even after the second debridement, there is still a growth of the gram-negative bacteria. And the patient has to go for a second debridement. You can see the first debridement was till here, but the second debridement is much more extensive. So the surgeon can decide the number of debridements depending on this camera. For your naked eye, you cannot see the bacteria. And once you start the antibiotics, you cannot keep doing cultures over and over again. Therefore, this camera will help the surgeon to decide whether more and more debridements are necessary. You can see that this is another picture of another patient. You can see the infection has both gram-positive and gram-negative. You have a combination of both infections in this wound. This was before debridement. Now, in some patients, even after the fourth day of debridement, you can see there is still growth of the organisms, the gram-positive, gram-negative organisms. So this is after the fourth day of debridement. So you have to debride further. And it also gives you the measurement in length, width, and area. It's a camera after all, so you can get the width of the wound, the length of the wound, and also the area of the wound. This is another patient after the second debridement. You can see that you have to debride more if the camera shows that there is infection. So this was the picture after the debridement, the first debridement. But after the fourth day, it's still showing organisms, and you then debride the second time. Therefore, such technologies will certainly prevent amputations. But as Professor Andrew Bolton and his colleagues published in Lancet, I think the most important fact is that about 85% of all the amputations in diabetes is preventable. It's due to infection. And if you do a proper debridement and get rid of the infection and also treat the vascular problems, you can certainly save many of the limbs. We showed that simple foot care education in 2005 again. We showed in this paper in Diabetes Care that by educating the patient long enough, you can prevent an amputation. We can't fix a problem until we know and acknowledge it exists. If you diagnose a problem very early, if you diagnose a bacteria which is infecting the person's foot very early, if you do a vascular intervention very early, you can prevent a messy job later. If you detect the leak quite early, you can prevent a disaster later. I would like to thank all my research and clinical staff at the MB Hospital for Diabetes and Professor M. Vishwanathan, Diabetes Research Center in Chennai, for all the good work they do and for helping me to make this presentation this evening. Thank you for your attention.
Thank you, Vijay sir, for an excellent talk and the new thing which we have learned today, and properly and then treat them, which we are not doing because the culture report will come after 3 days or 7 days. Till that time, we are behind because the infection spreads like a fire in the diabetic patients. I have seen in my hospital also. I am very much interested in diabetic foot patients. I am preventing the amputation in Jabalpur. No one was doing the diabetic foot practice here. But since 15 years we are doing here, and we are saving so many amputations. And I hope this new gadget will help in the future to prevent more further amputations. Thanks a lot for your excellent talk, sir.
Thank you, Ashish.
Saurabh, any questions?
I think there are no questions in the chat box also. And
So I have one question, Vijay sir. How much the gadget costs, this instrument?
Well, this was developed by a company in Chennai, and you can have two options. You can either rent it out from them, in which case you pay them a fee for each patient. We are paying about 150 rupees for each patient, for each photograph you take.
So how much is the charge for per patient?
Per 150 rupees. You want to use yeah, but if you want to buy the machine, the camera, they're charging some 3 lakhs something. So right now we are only renting it out, and we're paying per patient to the company. It's a company in Chennai. It's
okay, I will contact you. Yeah, it is a great thing. So Mithun, I have one question that the shockwave therapy, is it available in India for the?
Yes, it is available. Ashish, I've been using it for the past 5-6 years now.
Okay.
But you have to carefully screen the patients because it is expensive. So a typical shockwave, they recommend 12 sessions. That would, burn down for the patient to be around 60 to 70,000 rupees. So the problem is patients' expectations are very high when they pay so much of money. It's directly proportionate to what kind of erection they want. So if they pay 60,000, they really want a really good response, which is not possible.
Like in obesity, we face a situation like I have faced in one of my patients that डॉक्टर साहब मैं गैस खरीदूं कि आपकी दवाई खरीदूं मोटापा कम करने की मैं तो पतली हो ही नहीं रही हूं so they blame us. So you have to be cautious in these things.
Yes, so I think you need to warn the patient because the machine itself costs around 30 lakhs. And there's a reflector which costs around 83,750. That is for 12 patients. So it is an expensive therapy.
So any questions for Arvind sir?
I think
Would you like to add some?
No, I mean, I was actually listening to Vijay speaking about this. I think this is very fascinating because, even though we are told, in fact, trained under his father, that you always start off a gram positive, gram negative, both antibiotic to start off because you still need 72 hours before you get the report. Vijay, there can only be one thing, some of the bacteria, especially methicillin-resistant staph, those are the areas where MRSA is being picked up. I think that is where we can actually go wrong with this just gram-positive, gram-negative identification. Did you have a chance to see MRSAs when you actually did the culture and this going wrong there?
Yeah, I showed one slide. Maybe I didn't spend enough time on the slide. There were some 30 cases of MRSA out of 170. So it was not a very high prevalence. Like in the Western countries, we have very high prevalence of MRSA. In India, we don't find that much of a high prevalence of MRSA. So MRSA is there, but it will be categorized as gram-positive. And you still have to follow the guidelines of the IWGDF or the American Infectious Diseases Society and so on. You still have to follow that. This is just to help the physician, the surgeon, to decide about a second debridement, third debridement.
I think that was a very interesting point. You have already debrided and you're looking at an image which still shows that there is some infection. I think it tremendously should be helping the surgeons.
Yeah.
Dr. Arvind, can I ask a question?
Yeah.
Today weather is hazy sunshine, 38.3 degrees Celsius.
Hello?
Carry on, Dr. Rajesh.
Sir, I want to ask you a question. My experience with these non-mediatric cameras has not been very good. I have Trinetra. And what we do is we take pictures and we send them over to the retina specialist. So earlier we were taking without dilation, but what later we've had different retina specialists. All of them are of the view that it is important to dilate the patient. what has been?
I fully agree, Rajesh. Trinetra comes nowhere near Remedio's FOP, and it's not even FDA approved. And I think most of the people have given it up. And unfortunately, in India, what happened was there were some pharma companies which were buying and giving it to the doctors. I think you can stop using Trinetra. I'm sorry for saying this because the image quality is not good. Okay, now Remedio FOP has been compared with the best of the tabletop models, in fact, across the world. That's why it has got an FDA approval. I fully agree with mid-Adriatic versus non-mid-Adriatic because the pupil size among Indians sometimes is small. So if you are not getting a good quality image, because this FOP has an auto-click mechanism, so anybody who can just focus on the optic nerve or probably on the macula, it automatically takes the image. Suppose you find that the quality of the image is not good, then you can go ahead and dilate the eye and take it. And you may not get a non-mid-Adriatic image in at least 20% of your patients, wherein you have to dilate and take the images. And the important thing is, for ophthalmologists, if you are using teleophthalmology, it depends on how you are sending the images. If you are sending WhatsApp images, please stop it because there is a drop of almost 10 to 20% on the quality of the image size. It can make up most of the DMEs. I think these are the few things, because this is what has been done for a number of years by the physicians who are not trained in ophthalmology. So I think this change over a period of time, we'll see a number of physicians using FDA-approved devices. And all that it costs for the AI is about 50 rupees. And it comes loaded with some 1,000 AI diagnoses with the camera. And after that, each image is about 50 rupees, which is very affordable by most of the patients.
What is the cost of this Remedio?
I think they're giving it under 3.5 lakhs now. And RSSDI definitely were a part of this deal. All RSSDI members were getting it at 3.5 or so. But one can actually talk to the Remedio people and try to reduce the price further.
Yes, because the Trinetra is considerably, it is almost twice.
I mean, Trinetra went into a lot of problems because most of their parts were imported. They were not really doing it here because this AI was tested against most of the Indian cameras available at that particular point of time. And somehow we had a lot of problems testing it with the other cameras.
Thank you, sir.
Even Bosch came out with a handheld device, which would give
it wasn't steady. The only problem, Arvind sir, as you know, it wasn't very steady with the handheld.
It was very difficult to take it with the handheld thing. So the Bosch also stopped it. Technology looks simple, but when you actually do it, you get into all kinds of problems. Actually, I must thank Chennai because Anand Shivraman, who started Remedio, is actually originally from Chennai, and then he had to come to Bangalore because he got married to a Kannada-speaking girl. You know, that was the influence to get them to Bangalore to start this. Vijay, you should also now, I mean, you can't now, it's too late.
I think the only thing that this session has given me the idea is that all the three sessions were related to microvasculature. So I'm going to call Vijay sir and Arvind sir offline after this. It's given me an idea to tie the three around suddenly, which is not, we don't have much data on that. So call offline. Suddenly realize that these are all three microvasculature.
Yeah.
Thank you.
Like
I think excellent talk by Dr. Arvind sir, Dr. Mithun, and Dr. Vijay Vishwanathan sir as usual. Thank you, sir, for being here, sir.
Thank you.
Thank you.
Mithun, I enjoyed your talk.
Yeah. Thank you, sir.
And
Thank you,
sir, Arvind sir. Arvind sir,
Great talk,
enjoyed
sir.
your talk.
Great talk.
Thank you so much, sir.
Mithun's talk is usually enjoyed. Thank you.
Thank you very much. Thank you. Very kind of you. Vijay sir, there's a new thing called hemoglobin spray that has come up for wound healing. Have you? Not on mute.
You are mute. You are mute.
No, there are so many technologies, but I think you need randomized controlled trials because there are so many new honeys and everything, maggots being tried out. But I think we need randomized controlled trials because ultimately debridement, vascular intervention, offloading is what is preached by everybody.
Offloading works like wonders, sir. It is one of the treatment part. Offloading is very important tool which we are missing because we don't teach the patients when they go home. I think so. Offloading is a very important tool.
This, if I can say, Ashish, I presented some work in RSSDI Endocrine Society in West Bengal last week, where we showed some gruesome vascular disease, where we corrected by angioplasty and saved the limbs. There was absolutely gangrene and black tissue, and we did angioplasties and saved the limbs. So vascular assessment and vascular intervention has become the order of the day. And offloading, of course, is very important. But I think it's very important vascular control is very important. And
timely intervention is very important.
People are getting amputated because the surgeon is in a hurry to debride without looking at the vascularity. So we get a lot of patients who have gangrene because they're not even examined the posterior pulse or dorsalis pulse. They've just debrided. There's no hurry to debride. First you have to establish vascularity and then only you should debride. That's what we do. But many surgeons are in such great hurry. They see pus, they immediately go in and debride. You should not debride until you're sure that your blood supply is adequate to the pedal arches. And if you don't get enough blood supply and you go and debride, it will become a dry wound with absolutely no blood flow. And
so prerequisites should be followed, which we are not following. That is, we have to see the vascularity, neuropathy, all the things first we have to deal, and then we should go for surgery. That is the message.
Yeah.
A simple question that in the 3-tier cities in which these facilities are not available, what antibiotic you will suggest to start to the physicians?
So we have this guidelines from the IWGDF by Benjamin Lipsky. So supposing you have a fresh infection, which is less than 2 weeks old, not yet exposed to antibiotics earlier, you cover only gram-positive. You give only gram-positive. But supposing it's a chronic wound, more than 2 weeks old, with a past history of exposure to several antibiotics, you have to cover gram-positive and negative. If you have a foul-smelling wound, then you should cover gram-positive, gram-negative, and anaerobic cover. So clindamycin is a good, it covers gram-positive and anaerobes, clindamycin. You can cover clindamycin with some gram-negative cover. So the guidelines are very well written by the IWGDF and IDSA, Infectious Diseases Society of America. We have 2 guidelines for antibiotics, empiric antibiotics. Ashish, does it answer your question?
Yeah. Thank you, sir. Because I want to spread this message to the physicians because they start very late and the absurd antibiotics we are seeing in the prescription. So we should give a proper message to the physicians.
Start IV antibiotic if parenteral antibiotic if your infection is quite severe. Many people give only oral antibiotics. You can give oral antibiotics after 4-5 days. You should start intravenous to start with.
Thank you, sir.